Good morning, everyone. Today's case presentation is about a 61-year-old gentleman, Mr. Chandrakant, hailing from Bellary, who is a tailor by occupation, presented with complaints of dyspnea and exertion since 2 years, pedal edema since 1 month. He was apparently normal 2 years back. Then he started developing dyspnea, which was grade 2 initially, insidious in onset, and gradually progressed over the 2 years to grade 3, which was aggravated on exertion and relieved by rest. And history of pedal edema since 1 month, which rapidly progressed in the last 2 weeks with complaints of abdominal distension. No history of angina, no history of orthopnea PND, no history suggestive of infective endocarditis, no history suggestive of thromboembolism. Past history is a known case of hypothyroidism since 4 years on tablet thyronam 25 micrograms. No other known comorbidities, no history of previous surgeries, no history of rheumatic fever in childhood. Nil habits is a mixed diet. To summarize, a 61-year-old gentleman with dyspnea and exertion NYHA class 3 and pedal edema since 1 month. Preparation diagnosis will be of left-sided valvular heart disease in failure. General examination.
Why not a single play of mixed edema only?
It's been there for 2 years.
Poorly controlled thyroid disorder.
He saying that the thyroid levels are under normal. It's an under regular checkup and his dose has been the regular follow-up. And
Fine. Okay.
What are the usual presenting symptoms of a constrictive pericarditis?
Initially present with dyspnea and exertion, dyspnea, followed by abdominal distensions and pedal edemas. Failure symptoms, followed by failure symptoms.
The usual presentation is dyspnea and exertion. Sometimes there may be orthopnea also, especially if the patient develops abdominal fluid in the abdomen. And then when the patient lies down, get dyspnea. The second presentation usually fatigue. The third is abdominal distension, pedal edema. Then loss of appetite, and because of the congestion and difficulty to ingest enough food, and anasarca, all this comes. So first, of course, here dyspnea, non-exertion. Okay. Chest pain. Another person with chest pain.
Chest pain, not usually, sir.
Pericarditis usually presents with chest pain initially, but when it comes to constrictive pericarditis, the pain, because initially pericarditis presents with classical chest pain because the two layers of the pericardium, inflame rubs with each other, and they get typical chest pain, even radiating to the shoulder and the neck. But once the constriction has occurred, usually dyspnea is the first percentage. And then anasarca, edema, and liver and pain.
Even we can't think about constrictive, isn't it, sir?
Yeah.
We still don't know. He has to come up with that. We can't discuss about constriction right now with the history that is given. It's just dyspnea and pedal edema. So more likely that you have to discuss this as a case of left ventricular failure and then other things. So that would be the primary thing that comes to your mind. Constriction is not very common.
Yes, sir.
You may know the diagnosis now, but don't discuss this straight away from the history.
Yes, sir.
Okay. Now what do you do?
General examination is a well-built, well-nourished, oriented, height of 164 centimeter with weight of 74 kg with BSA of 1.84. No pallor, icterus, clubbing, lymphadenopathy, or cyanosis. There is a bilateral pitting pedal edema with scrotal swelling and abdominal distension present. JVP is elevated 12 centimeter of water with rapid X and Y descent. with Kussmaul sign being positive, like failed to drop in JVP during inspiration. Pulse 74 per minute, regular, normal volume and normal character. All peripheral pulses felt, no radial, radiofemoral delay or pulse deficit.
What is
BP,
Kussmaul? Excuse me.
so during failure to drop in JVP during inspiration. Persistent rise in JVP during inspiration.
It will raise instead of falling. When
Yes.
the chest expands, normally you expect the JEP to fall. It raises instead of that. That's Kussmaul sign. Yeah, okay.
BP 124 by 76 millimeter mercury in right upper limb in sitting position. No BP variation with the respiration and saturation of 97% on room temperature. Systemic examination. On inspection, apical impulse not seen. No scars, dilated veins or obvious deformity. On palpation, apical impulse not palpable. No thrill or palpable heart sounds. Auscultation, S1 and S2 normally heard. And there is additional high-pitched early diastolic sound, which is pericardial knock, best heard in the left fifth intercostal space, is medial to the midclavicular line.
What is the timing of pericardial knock?
Early diastolic.
What are the characteristics of pericardial knock and when do you hear that?
So it's a high-pitched early diastolic sound, which you will hear in the rapid ventricular filling phase.
Not really. I don't think that's the proper definition.
The differential diagnosis of that is usually opening snap. But the pericardial knock comes at a later stage. It's due to not the rapid filling, because of the rapid early diastolic filling, there's a deep diastolic. Then suddenly the myocardium comes in touch with the constricted pericardium. That's the time it shows a pericardial knock, which is equivalent to what you call the cat square root sign. The dip followed by the plateau. At that stage, it comes and hits and then suddenly stops. The dip and plateau sign or the square root sign in the ventricular tracing of a cardiac cath.
In the acute phase, you will generally get a pericardial rub. In the effusive constrictive stage, you will get a pericardial knock. And once the whole thing becomes fibrosed and there is cross constriction, then the pericardial knock also disappears in the later stages. Okay.
Usually, olden times, we say diagnosis depends on the Beck's triad, BECKS. What is Beck's triad?
Raised GVP, muffled heart sounds, and low systolic pressures.
Very good. Muffled or distant? Yeah. Okay.
Other systems, respiratory system, there is normal vesicular breath sounds, no added sounds. Per abdomen, abdomen is distended. There is hepatomegaly. The liver is palpable 3 cm below right costal margin in the midclavicular line with a liver span of 12 cm. There is shifting dullness present, no fluid thrill. Neurological examination is normal, no focal neurological deficit.
Anything to add to that hepatomegaly?
Other organs, splenomegaly, no organs.
Is it tender or not?
Yeah. Tenderness as well as is it style?
Yes.
And you have to exclude a pleural effusion also when you do the chest examination.
Yes, sir. Diagnosis will be a 61-year-old gentleman presented with the dyspnea on exertion since 2 months and pedal edema since 1 month. The case of constrictive pericarditis in NIHA class 3 in failure in sinus rhythm with no infective endocarditis, thromboembolic episodes of pulmonary hypertension.
What's the etiology of constrictive pericarditis? You didn't talk about history of causes. You didn't talk about
here it's most likely idiopathic. or viral, because in India most common will be tuberculosis, but he didn't give any tuberculosis history.
What are the other
Okay.
causes of pericarditis?
Idiopathic or viral, post-surgical, post-chemo radiation, and autoimmune disorders like sarcoidosis can cause.
Yeah. If it is not tuberculosis, the next common diagnosis would be post-surgical. Although in this patient, he had no operations done. Post-surgical constriction is quite common. Okay.
Then there may be traumatic, a closed chest trauma producing hemopericardium. And then the uremia usually produces pericardial effusion, but maybe a rare cause later on to produce later. And then in children, the usual thing is a pyogenic pericarditis. Any sort of pericarditis can lead to constriction, except probably the rheumatic. In the acute stage of rheumatic, the pancarditis. That pericarditis almost never leads to constriction. But in India, very common is pyopericardium, partially treated or just treated with a
Pigtail.
aspiration or by the cardiologist with a pigtail catheter, then partial pericardiectomy. All those things may lead to constrictive pericarditis. So in India, tuberculosis and after that probably post-surgical, median stenotomy and cardiac surgery, post-surgical and probably post-pyopericardium, imperfectly treated.
Yes.
If you get a case like this in the exam, you have to differentiate three conditions. One is cardiac tamponade, one is constrictive pericarditis, and one is restrictive cardiomyopathy.
Yes, sir.
Do you know the differences, clinical differences?
Yes,
If
sir.
you know, you tell us. Otherwise, you have to go back and read.
Okay. In cardiac tamponade, clinically, the X-ray in JVP, X-ray, Y descent won't be there. This is prominent in CCP. And in restrictive, we'll more on the investigational findings will evaluate, like in echo findings.
Cardiac tamponade is usually an acute event. You will have a raised JVP, but you will not get ascites and this thing. That's a late phenomenon.
Yes.
The gross ascites and effusion, pleural effusion, and pedal edema, it's more likely that it is a chronic. So there you have to know about constriction and restrictive cardiomyopathy. These are the two classical diagnoses which you are dealing with a case like this.
Yeah, good. And the other thing, first thing you should say, the tamponade presents with classical pulsus paradoxus.
Yes, sir.
Paradoxus is not present in all cases of constrictive pericarditis.
Yes, sir.
Usually in effusive constrictive pericarditis, or only 1/3 of the constrictive pericarditis, the pulsus paradox is present. And the restrictive cardiomyopathy, you have to diagnose probably by investigation. Only thing, pulmonary hypertension may be often associated with a restrictive cardiomyopathy, but pulmonary hypertension is not usually clinically not associated like loud P2, not with a constrictive pericarditis.
Yes.
All right.
I would like to investigate further to confirm my diagnosis and for the further management. ECG, the standardized ECG, which showing
what could be the etiology in this case, you think?
it could be idiopathic, sir, or viral. But viral then give mostly idiopathic.
Yeah.
ECG showing sinus rhythm with heart rate of around 74 per minute. It's showing low voltage QRS complexes in the chest, all over the low QRS complex with the T wave inversions and flattening in the chest leads, which is findings seen in constrictive pericarditis, which correlates with my diagnosis.
Good. Low voltage currents complexes, then flattening of T wave or inversion of T wave.
Okay.
Yeah.
Chest X-ray, well exposed, centralized, slightly rotate to the left. PAV chest X-ray is showing CT ratio of 0.5. There is a calcification noted in the left border and over the inferior border of the heart with increased bronchovascular marking.
That gives you the diagnosis straight away.
Yes, sir.
Calcified pericardium.
Yes,
Right?
sir. Yes, sir.
And there is no cardiomegaly. That is important.
Yes.
And also there is no effusion. You have to note that there is no effusion in the height of the hemithorax.
Yes.
But this is a not well taken X-ray. Looks more like a lordotic view because both the diaphragms appear to be at the same level.
Yes. Echo, sir.
Go on.
Can you hear me, sir?
Yeah, now we
Yeah.
can.
Okay. So echo is showing the features of constrictive pericarditis is a EF of 45 to 50% with diffuse pericardial thickness with irregular calcification with maximum thickness towards the posterior wall, which is 5 millimeter. And there is a IVC is 27 mm dilated with the collapsibility less than 50%, with RA pressure being 15 millimeter mercury, with the exaggerated hepatic venous diastolic reversal is seen. In intraventricular septum, there is a septal bounce and septal shudder is seen. In mitral valves, there is a significant respiratory variation with the both mitral and respiratory, mitral and tricuspid valves, which is 32% in the mitral and 37% in the tricuspid valve. Other valves are normals.
You should also mention about whether there is MR or no MR. Is
The
that
mild
possible?
MR.
Is that possible? If so, why? Why will you get MR in? Because there may be constriction around the AV groove, causing distortion of the mitral annulus. Okay. MR can happen. So MR is one thing that you should know as a surgeon, and then also there is a constrictive pericarditis. Some amount of it. Why is it important to you?
What do you mean by septal bounce? The echocardiographic sign of constrictive pericarditis.
So paradoxical movement of the septums, like when the arc picks up, the septum moves towards the LV, which causes underfilling of ventricular interdependence.
Yeah. In the early phase of diastole, and the right hand fills up markedly, the septum moves towards the left side. In the later phases of diastole, the septum moves to the other side. That's why it's not a septal bound. That's one of the characteristic sign of. And the other thing, most important thing to differentiate between a restrictive cardiomyopathy is to find out the diastolic dysfunction by finding the EA ratio, factor inflow EA ratio. But when you say 1.8, what does that mean? Is there a diastolic dysfunction or not? Or in other words, all of you should know what the Grade 1, 2, 3 diastolic dysfunction by ERS. Let's go and read it and okay, all of you.
Yes, sir.
How to make, because that's the most important diagnostic feature to differentiate between a restrictive cardiomyopathy. Other than the pericardial thickness of more than 5 millimeters, some people say 4 millimeters calcification. Those are all in favor of constrictive pericarditis, and the diastolic dysfunction is more in favor of a restrictive cardiomyopathy.
At your stage, you must also know the differences, how to evaluate systolic dysfunction of LV and the diastolic dysfunction of LV by echo.
Okay.
And what are the causes causing these two, right? So these are few things that you should know.
Okay.
And the question, going back to the question I asked, was if it is effusioconstrictive, it is easier for you as a surgeon because you have a plane between the pericardium and the visceral pericardium.
Yes, sir.
Right? So it is much easier to do your pericardectomy if you have effusive-constrictive pericarditis. But in the late stages, that effusion gets absorbed and becomes fibrotic, then you have trouble doing the pericardectomy.
Yes.
Do you want to do cath or not in this patient? And then if so, what is the findings?
Cath is really not required in this case, sir, because it's clearly the constriction is clearly established in the diagnosis. If we do cath, we can see the findings of increased RA pressures and equalization of diastolic pressures of all four chambers within the 5 millimeter mercury range. And
Correct. Good. But age of this patient?
Sir?
What is the age of this patient?
That's not done.
61, sir.
Huh?
61, sir. We will be doing coronary angiogram. At that time, we can do.
So that
61.
is part of catheterization.
Sir?
Coronary angiogram is also part of catheterization.
Yes, sir.
What are the different things in a cath? What all do you do? When you do a catheter study, all the things that you will look for. One is the core catheter.
And then oximetry, pressure studies, and the angio.
For pressure studies, the second is the oximetry, and then the pressure study, and then and both selective angiogram, coronary angiogram, and RV or LV angiogram, so that you know what is the structural abnormality. These are all the components of cardiac cath. And as you rightly said, there is equalization of the diastolic pressures in all four chambers.
Yes.
As against equalization of saturation in all four chambers is seen in where?
PAPVC, sir.
PAPVC. Good. So these are classical things that can happen. And then the examiner will ask you the same question.
What exactly is square root sign?
The square root sign is like.
What's the other name of square root sign?
Dip and plateau sign.
Dip and plateau. Dip and plateau sign. What exactly is square root sign?
Because of the initial dip followed by rapid rise and plateau of the ventricular
First
pressure.
say it is the ventricular tracing during cardiac catheterization. Yeah. Okay. Proceed. Yeah. Initially, there's a rapid filling phase during the diastole. Then there's further dip, the dip diastolic pressure. Then there's a rapid increase of pressure, and it ends with a plateau. It ends with a plateau when the myocardium didn't come in contact with the pericardium, which is very stiff. It cannot dilate anymore. That's the square root sign of a dip and plateau sign. Okay, so important say diastolic dysfunction and the thickness of the pericardium to differentiate between a restrictive cardiomyopathy and pulmonary hypertension is usually absent in constrictive pericarditis, but it's often present in patients with a cardiomyopathy.
Yes.
What are the causes for restrictive cardiomyopathy?
Very often is infiltrating. What infiltrating?
Amyloidosis, sarcoidosis, carcinoid, myocardial fibrosis.
What's common in our country, especially South India? To be more precise, Kerala.
Don't know.
More commonly seen in the coastal regions, sir, or all
Yeah,
over?
it's a endomyocardial fibrosis, mainly of the right side. Dr. Valiathan has introduced this endomyocardial that thick excision.
Extensive
Maybe
done by
yeah,
in Chitra,
yeah.
Chitra.
It can be bilateral also, but in certain areas of Kerala, they say that's maybe because of eating of the tapioca. Similar thing is in East Africa, they say tapioca is known as cassava there. I think Valiatan has done a lot of research on that. So in that area, East Africa also this is common. So he postulated this maybe because of the eating of the Kerala fellows eat a lot of tapioca. Anyway, so here's described the right ventricular EMF, endomyocardial fiber.
So usually you will see that there is the apex is obliterated in the echo, in the right ventricle, and usually confirmed by cardiac biopsy.
Oh.
Read about restrictive cardiomyopathy as well, because whenever you get a constriction, you will get questions on restrictive cardiomyopathy and vice versa. If you have, we hardly see any restrictive cardiomyopathy so often. So if you get that, you will be asked about constriction. Now, what do you want to do with this patient?
So I would like to have a surgical procedure, pericardectomy for this patient.
Why surgical? Why not medical management? People, cardiology colleagues will tell you, oh, we will treat you without any incision surgery. We will treat you with a pigtail catheter and drugs. Why you have to go through surgery?
It's already symptomatic and is in failure.
Hmm.
Like any symptoms are there, and there is a 5-month thickness of pericardium which is in the echo.
But gross ascites, gross this thing JVP raised, and a severely thickened pericardium with calcification. Is that a plus point or a minus point? Calcification.
Is minus points.
Yeah. If you can get a plane and between the visceral and the parietal pericardium, usually the calcification is mainly in the parietal pericardium. If you get a proper plane, it can be removed easily. But if the whole thing is grossly fused, then you have serious trouble trying to do a pericardectomy.
Yes.
Now, if you want to do surgical management, what is your approach? How will you do?
Medial sternotomy half pump strategy, sir. So,
Median
applying.
sternum off pump.
Yes, sir.
Is that that's not normally in your, that's not the NH this thing, is it?
Yes, sir. That's what here Sanjay sir does.
Sanjay is the one who does that because he's trained from KU, but otherwise everybody in NH will like to put him on pump. Anyway, it's okay.
Others most not doing. Only Sanjay sir is doing very good at things, sir.
Correct.
We have seen him only.
Correct.
So, either you can do either on pump beating or we can do this one, sir. Off pump.
And why median sternot? What are the other approaches that are?
Other approach is a left antral thoracotomy, sir. The left antral thoracotomy, we can access the LV very well, but the right RA, with the RA, SPCI, side won't be, access won't be enough. And in case we want to go on pump on emergency, it will be we have to go on peripheral. That will be a difficult process.
Yeah. Okay.
Median sternotomy, we can have the good access all over, sir, and we can go on pump if required. I don't think.
All right. So once you do a median sternotomy, what are the monitoring lines that you want?
Central line. Central line and arterial lines.
Good enough, right?
Yes.
Yeah. Central line will tell you whether you are doing the right job or not, because
yes,
as you are doing the pericardectomy, you will see the JVP falling down in front of your eyes, and even the ascites, if you have done a proper job.
Yes.
So we all used to do this quite often. And okay, then what do you do? Where do you start? You see, you
So we have
open the
to detect the LV side first.
Open the you have done a sternotomy. Then what do you do next?
So we have to create that plane of dissection. So basically, we'll make a cruciate incision and lift all 4 flaps to see where the epicardial coronary pulsation, like that will be the landmark or plane to proceed.
What is the plane?
The epicardial, the coronaries.
Coronary. Yes, you should be able to see the coronaries well. Okay. Now,
and then I will start dissecting LV side first.
Where will you make the cruciate incision?
On the LV side first. We'll release the LV.
Why?
Suppose if we release the RV first, the patient will end up in the pulmonary edema because the LV can't handle the volume. It will end up in pulmonary edema.
So
we have to release the LV.
As the dictum is that you do the distal most first and then come proximally.
Yes.
Okay.
Yes.
So same thing in congenital hearts also. You do the distal lesion first and then come proximally. So
yes.
LV, you do a cruciate incision on the LV and then gradually lift the 4 corners and then keep proceeding until you release the entire LV. Okay.
Yes.
What is the sequence of release of the pericardium? LV first and then?
LV first, then it will be inflow, sir, and then RV, and then
LV, R, and inflow.
Yes.
Yeah, inflow is last.
Okay.
And the most dangerous part of the operation is by the time you come to the RV.
Yes.
RVOT is the most delicate structure at that time. And by that time you are fatigued and invariably you cause disaster in that area. Okay? So you have to be very, very careful about the RVOT. Okay. And then necessary, take a little break, have 5 minutes break. Disaster.
Okay.
All right.
Yes.
So RVOT is the most difficult part of constrictive pericarditis. One, because it is very thin, and secondly, by the time you reach that area, you are fatigued. because it's a tedious process. It's a very long, tedious thing. You have to be very gentle and then gradually lift the things and come up. And as you rightly said, you have to release finally the inflow, both the SVC and the RA,
Yes.
right? Okay. And then the plane is that you should be able to see the coronary swell.
Yes.
Okay. And then as you keep coming proximally, the JVP starts falling down. As the left ventricle starts contracting well, the JVP falls down. And also you can see on table that the ascites disappears and the hepatomegaly just regresses. It is a very dramatic thing that happens on the table. If you have done enough of those, you will know. Okay. And also be very careful that you should keep the pump on standby if necessary, but more so a 5-O-proline mounted on a Castrovia needle holder all the time, because you can anytime injure the myocardium, and then you may need to take stitches. So that should be there on the table, more loaded and kept. So what are the pros and cons? So here, from the median sternotomy approach, where all will you release the pericardium?
From lateral extent will be 1 centimeter anterior to the phrenic nerves on both sides. And from base till diaphragm we have to release.
1 centimeter is a long distance. Almost phrenic to phrenic, you have to come. Just a few millimeters away from the phrenic is fine. Okay? Otherwise, 1 centimeter is quite a lot of distance on both sides. You will not have adequate release. And then go on to the diaphragmatic surface and the apex of the ventricle. Okay, you can just release that. All right?
Yes.
What is this called? This is usually called as a subtotal pericarditis, because you cannot remove all the pericardium all over, especially over the LA, because LA is the posterior organ. Chamber. You understand?
Yes, sir.
So when you do a left thoracotomy approach, it is usually termed as partial pericardectomy, and when you do a median sternotomy approach, it's called a subtotal pericarditis.
Yes.
And sometimes if you have a disaster on table, especially like I said, the RVOT or somewhere where you have massive bleeding, then you have to go on an emergency CPB.
Yes.
Otherwise, generally, CPB is not required for just a pericardectomy. Anything to add, sir?
Yeah. I'm saying about the old time from CMC, we have published one of the largest series of surgery for constrictive pericarditis. 100% we used to do them from the left anterolateral thoracotomy. And as Krishna said, in that case, it's easy to release the left ventricle more from there. You can go beyond the left phrenic nerve behind, and it's easy to remove the thickened pericardium from the diaphragmatic surface also. But as he said, the most dangerous things in the RV outflow. And if you make a hole through the, when you are approaching the left thoracotomy, that's a disaster. That usually ends up in death on the table. And then later on, most of the people, they are now doing through a median sternotomy. But still, I think if a patient is for the diffuse constrictive pericarditis due to post myocardium, then it's better to do to the left thoracotomy because middle thoracotomy is a chance of tunnel infection. If you are doing for a effusive constrictive pericarditis due to infection, otherwise, most people have turned to median. Even median sternotomy, it's not a complete pericarditis. As Krishna said, it is subtotal. Not only phrenic to phrenic, but you can go behind the phrenic also to a little bit extent. In the left thoracotomy, people think that's better to release the most of the left ventricle, which is the main pumping chamber, and part of the right ventricle. That's enough because the main problem is because of the LV and RV cannot dilate because of the constriction. But many cases you find constriction around the right atrium, around the SVC, around the IVC, and as Krishna said, if there's a tricuspid or mitral regurgitation, it means there's a constriction around the AV groove wall. In such cases, also it's better to do from the medial sternotomy you can. And also, we all used to think that, the pericarditis under CT is contraindicated, but now more and more people are moving into pericardectomy on cardiopulmonary bypass because you can do a total pericardectomy in that case, and the chances of recurrence are much less. Even otherwise, if you're a safe surgeon, through medial sternotomy, it's better to prepare the femoral area so that in case you are trouble, you can quickly cannulate and go on. And on bypass also, peripheral cannulation go on bypass, but it should never be done under cardioplegic arrest. It should be done on bypass with a beating heart because that's the most important thing. When you make a crucial incision, normally when you open, you find no pulsation at all. When you start the crucial incision, cruciate incision, and then suddenly start the myocardium bulging and the coronary tearing. So it can be done safely with cardiopulmonary bypass, but without cardioplegia on a beating heart.
What is turtle cage operation?
Yeah. Do they do on CP bypass pericardectomy in this hospital? Okay.
No, so they do half pump only. Yes.
Yeah.
Only Sanjay sir does. He does.
PV Rao
No.
used to do some of
Only
them.
Sanjay who does off pump, all the others used to do it on pump, and nowadays only Sanjay is the only person who's doing constriction. Earlier they used to come to me also, but nowadays it's only Sanjay who does the constriction. But the other surgeons who used to do it on pump, but now they have given up.
Okay.
Now coming back to my question, what is turtle cage operation?
Turtle cage, we will leave the islands of pericardium over the we can't able to remove completely. We'll make the grid incisions, grid pattern.
Yeah. So when the pericardium is densely adherent to the myocardium, and you're not able to strip it off the myocardium, and it causes damage to the surface of the myocardium as well as the coronary, epicardial coronaries, you tend to leave behind islands. You just make incisions on the thickened pericardium, parietal pericardium, and leave islands in between, so that the myocardium in between these islands tend to distend the myocardium, and then the constriction is released. This is done as a bailout procedure in case you cannot do a complete pericardectomy. I mean, a subtotal pericardectomy. So this is something that you should know. That too, and then even in this, you can relieve the constriction, and the JVP will come down quite drastically. This is only done as a last this thing resort when you cannot do a proper pericardectomy. So you must know how to do that, and it should be in the armamentarium of all surgeons. You must know how to do that, when to stop, and at what depth you have to stop, and things like that. It's important to know that. We do a similar thing even on the densely adherent pleural thickening on the lung parenchyma. So a similar thing can be done there as well. So the thing to understand is that it is a tedious process. It has to be done gently with a lot of patience, and especially over the RVOT. It's a disaster. I have seen one disaster, and as Sir said, it is if you've got a problem there, you have got a death on your tail, which is not acceptable to any surgeon.
What are the post-operative complications and what the usual management in the post-operative period?
Post-op usually will do fluid restriction. That's one main
And
thing
what
will
the
be
post-operative complications you first see?
low cardiac output.
The
The most
low
important.
cardiac output is the most important complication. Why?
Because the LV will be, suppose the LV will be chronic. In chronic cases, it would be the fibrosis would have been set.
Very good.
So
Because long-standing chronic constrictive pericarditis affects the myocardium also. So the myocardial function may be less. Usually, the most common complications low cardiac output. How do you manage post-operatively patient with after resection of constrictive pericarditis? You said low, you mean fluid restriction.
mechanical ventilation.
In olden times, we used to say, I don't know how they practice it today. First, ventilate the patient at least overnight, because that takes off work of breathing from the cardiac output, especially if the myocardium is damaged. Then, usually we start some small dose of inotropic because if the myocardium is affected. Number three, severe restriction of fluids. Why is severe restriction of fluid?
Because LV won't tolerate. Not LV is not used to the high volume.
Yeah,
It will fail.
because once you release the obstruction, the central venous pressure comes down. So all the anasarca, the fluid in the legs and from the extravascular compartment, they come back to the vascular compartment, and then with a severe overload of the the left ventricle mainly, and also partly right ventricle. So it's better to go slow on the fluid intake, restrict it, and then inotropic support. I don't know whether they do that nowadays, and ventilate them instead of extubating them immediately. Of course, operatively, maybe bleeding.
Yes.
And then later on is a reconstruction. If you have done only a partial or subtotal, there's a chance of reconstruction occurring later on. What is the post-operative management in this hospital? Do they routinely give some small dose of inotropic? Do they ventilate them overnight? Or do they
Yes, sir. They will ventilate overnight, and fluid restrictions will be there, sir.
Good.
Inotropes, I'm not that sure. Like,
I suppose every single cardiac patient will have a low dose inotrope coming over.
yes, sir. Yeah.
So I don't think that is a thing. So inotrope, yes. Ventilation, yes.
Fluid restriction also.
Yeah. Okay, if there is a case of constriction in the wards, you will definitely get a constrictive pericarditis case for exam. So you should know about it, and then also know the differential diagnosis, both clinically and by investigation. All right.
Yes.
Good.
What do you mean by pulsus paradoxus and how do you measure that? What's pulsus paradoxus?
The pulsus paradoxus is a drop in systolic blood pressure more than 10 millimeter mercury on inspirations.
Yeah. You
That
first
is
said
more.
that it's an exaggeration of normal situation. Normally also, there's
There
a
will be a drop.
during deep inspiration, the BP recorded may fall 10 millimeters mercury. If it is more than that, then how do you measure the pulsus paradoxus?
So we'll inflate
By
the BP curve beyond.
sphygmomanometer.
Yes, yes, sphygmomanometer. We'll inflate the BP curve, and first we'll mark the appearance of first cortical sound. And then on inspiration, that cortical sound disappears and will appear after more than 10 millimeter mercury difference. The appearance of a cortical.
Yeah, in both cycles of respiration, you mark that by going down by 2 millimeters so that you can make when the sounds appear. And it's of course better by intravascular. If you put a catheter, you know exactly and measure on the screen, you can see the pressure difference, systolic pressure difference between inspiration and expiration. You can find the pulsus paradox.
So what is pulsus alternans?
That is alternate high volume and low volume pulse.
Why does it occur? You see pulsus alternans.
In LV failure, because of the LV failure.
Yeah. Why do you get this alternance?
No.
Anybody? I also have forgotten the exact pathophysiology of that. So anyway, please, it indicates LV failure. That much you should know. And then why does it occur? What is the alternates component of it? Please go and read about it and let us also know. I have forgotten. I don't offhand remember the exact mechanism.
Okay.
Another question some examiners used to ask is, the patient has got a cardiac tamponade, but still pulsus paradoxus may not be appreciable. What are the conditions? 1, 2, 3, 4. Where there's a tamponade, but you cannot appreciate the pulsus paradoxus. Anybody, any final view? That examiner wants the answer. 1, in the presence of atrial septal defect, the pulsar paradox is mainly because during inspiration, the right side feels much more. So much so because in a restrictive pericardium, it compresses on the left ventricle, so the left ventricle output becomes less and so it leads to a pulsus paradox. So what they said, 1, in the presence of an ASD, the pulsus paradoxus may not be appreciated even in the presence of a cardiac tamponade. Number 2, they used to say, is when the left ventricular failure or the right ventricular failure is there, it may not be. And the third thing is, you can never appreciate the pulsus paradoxus on a ventilated patient. Because it's an intermittent positive pressure ventilation. It's not the normal breathing when inspiration, the intrathoracic pressure goes down and a lot of return from the IVC and SVC, the right side of the ventricle. So, in intubated, paralyzed ventilator patients, pulsus paradoxus will never be seen either on the trace or by palpation. This is the answer that examiner wanted. I think Solomon is there, I don't know. Okay, good. So most important, you didn't mention all the causes of restrictive myocarditis. There are so many. So
Yes.
difference between differentiation by investigation by of restrictive cardiomyopathy and constriction, and the importance of CT and CMR in the case of diagnosis. Okay.
Most books give you a table differentiating
Yeah.
the two. Make a take a picture of that and then keep it on your phone so that you can keep looking at it on and off so that you don't forget it.
Okay.
Good.
Right. Okay.
Okay.
Okay, sir. Thank you.
Thank you very much. Thank you.
Thank you, sir.
Thank you.
Yeah.